Francis Feldman interviewing Areta Crowell, Crowell, on 3/22/99 at the home of Francis Feldman. Voice on this. This is an interview on March 22nd, 1999 with Areta Crowell, retired director of the County Department of Mental Health. Areta, will you say a word or two so that we can see how your voice comes through?
I notice your questionnaire starts off with, how did you get into social work? Of course, I'm not a social worker.
Oh, that's all right, because not all of these...
No, I know that, but I thought that was...
Yes. Now let me now go back. That is going, yes. All right. Why don't we start, Areta, with your telling us how you got into the field of mental health?
I am a psychologist in New Jersey with a psychologist at the university where I was teaching who had a very strong background in demography and social planning analysis. And he got a job as the Director of Research for Los Angeles County Department of Mental Health and left the university in New Jersey to come here. That was an NIMH-funded research project.
Who was that?
George Mowat was his name.
I remember him.
George. Grant was awarded due to the work of mainly Don Schwartz, who was the chief deputy of the Department of Mental Health at the time, and who felt that what was going on in terms of community mental health needed to be documented and tracked and evaluated, and George was recruited for that position. After he came, by training a physicist, his work had to do with the properties of the components of...
Born on the East Coast?
No, I'm a Canadian by background. We went to Bell Telephone Labs from Montreal. Both of us got our PhDs at McGill. And he had a professorial career there and worked at a private university in New Jersey. When we first settled in, I was not particularly eager, but I wanted to look for something, and George actually introduced me to Arnie Weiser at the Center for Training in Community Psychiatry. And as cross and intertwined, George Wolkin had been there, and George was recruited by USC, Department of Psychiatry, to do some research there, so there was took it when went out thinking it was to take health and worked at the Center.
Helen How you came to know her?
I knew her before that. And I went to work there because of the work we had done before I went to that center. But anyway, that was what I was looking at when this opening came in the department, which I think was quite serendipitous because it was really an exciting opportunity to develop a whole program. The first thing that George worked on was a census-tract street index, which did not exist, as a way to be able to, on a continuous basis, relate where people lived to the geography of the county so that you could plan for service delivery. I mean, fundamental concepts, but nobody had put the tools together for Los Angeles. So that grant was basically used to set up that whole mechanism for Los Angeles County and was used by other at the Sheriff's Department even. I mean, talk about using county resources. So that was one of the things. And one of my first jobs was to do essentially a demographic map.
What year was this, do you recall?
The year I went to the county was December 1966. And in 1967 and 1968, we were mapping the geographic distribution of the home, the point of origin, of all the clients in the state hospitals. There were about 5,000 LA County residents at Metropolitan right then. And of course, there were no computerized records or anything like that. What there was a card file of all the people, and a lot of the information on those card files was very poor. Mm-hmm. So we sent clerks out there to thing, and then be able to very complex project for the time as a basis for planning the distribution of where clinics should be developed. What happening in the county at that time was post Watts riots planning, and people concerned about the impact of the riots on the community. Deal of sympathy of the recommendations that came out of the commission that made the study, operated with the applied for federal funds by about the time that the county started to work on building a hospital in that area.
These centers were
at the whole geography. There was Central City and Kedron. Gateways was north of that, but Central City and Kedron were a large area, and the rules with catchment areas. There was, a lot of support for that kind of facility and program development, and the counties, the areas of the county related, also needed to help the background for a lot of community outreach activity that was going on in the community. And our community mental health started, then they took their neighbor at in the schools of doing this effort in terms of what they were doing, and most of the effort really went into meeting principals and talking with them enough that they would be interested in having a psychiatrist come into the school. To the school leaders of that program recruited, so there was a very heavy emphasis in South Central on how important that was to his world. It would be agencies to take care and boundaries for humans. Finally got the Board of Supervisors to pass common boundaries in 1995, thereabouts. It wasn't quite
1995.
It wasn't quite that late, but it was 1993 or thereabouts when they finally passed a recommendation from the Children's Planning Council that there be common planning boundaries. And I invited Dawn to come in and say, Dawn, you at least ought to know that finally there was some official action.
I'd be very interested.
Part of the theme was to require the counties to have an annual plan. Then I was appointed to be in charge of the division from a pre-distress. This was going to get things done in that huge bureau. Happened. Much of it was passed. So it was in flux and turmoil, and there had been so much change from the beginning of the department with the idea that we were going to have a system of community mental health and get it into the regular for 55 catchment areas in Los Angeles County. And at that time, the vision was that every catchment area would have a hospital, an outpatient clinic, a day treatment program, kids programs, adult programs, community consultation, outreach, just the whole panoply. I can remember one application that went into the feds for $5 million for one of those catchment areas, and that was at a time when the whole vision in some areas off in the early 70s, so that
many of those catchment areas finally did have
federal centers. There was one rapidly, and always a difficulty in adjusting to the separate pace of demand for the mental health programs compared with what was largely running hospitals. And in those days, running hospitals was a big young man who would do large. He knew about moved in the budget. Always have not adjust to that kind of management nicety. Reference community accounted for and Goverty area influence issue, but to get the staffing. Director of the Department of Medicare before that, just to get it started. Roger was the medical director of the county hospital. During that job, just did it to get it off and running. And I'll have to hear from you more of the details about the controversy when Harry took over the job. I've heard some of it from him and some of it from being around and being aware through those afterwards. But went around the catchment areas and develop and own that center. We gave a lot of technical assistance to the East LA. His next set of fights had to do with the changes in the Landerman-Petra short legislation and his belief that Paul talked a lot about how strange it was that legislation would really change and set up your infrastructure service that you're going to have those changes from the federal monies. Community have agreed with the development approach enough. The legislation should have said the money will be transferred. If it had said that, some small mechanism like that, it would have made an enormous difference in what mine was the governor's budget for the year and saying, well, it's another increasing budget, aren't you all lucky? And there was high inflation, obvious could do, or something, just anything, but to pretend that the rest of us couldn't add 1 and 2, that was, and it's got quite a bit left.
Yes. It was facing away so I couldn't see.
LA County, at least, did not give credit and recognition to the social workers who worked at
in recent mental health, private practice.
Yeah.
Or interested in
in the public sector. Right. Okay. Harry's next big challenge came with the merger of mental health into the Department of Health Services. And he tried politically to stop that. I think he didn't have a chance because he did not have a very good reputation as an administrator, even though I've talked about the administrative problems of the health and hospital directors relative to mental health, which they couldn't deal with very well either, but that was why I think the merger went ahead and happened and all of the things that came from that. So acting on an interactively and worked with, had a merger of mental health and health, or maybe they had it all along, but he ended up being the health officer for Orange County for a while, and Ernie Clotty, who had been a state hospital superintendent for the state, was very involved in all of the statewide issues in terms of what needed to be done, what the legislative problems were, how to lobby the budget and do all those kinds of things. And I had asked Dick to be on the advisory panel I ultimately left the county and went to the Center for Training in Community Psychiatry, and while I was there, I got Dick to be on my advisory group for that project. And impressed with administrative voice, and I was at the time the health training level. I mean, my job then was that to Los Angeles County, but also have it be common language and common framework for the entire state, and a long collaborative process with the stakeholders in California to do that. And I staffed that first few months, who was at staffing it and did some of the preliminary work, and that was helpful for a lot of places in the state. It focused on a lot of conflict around the state. Defending, she told us to this, and it's not bitterly angry at Dick Elpers for reducing up and down that he did a conversation with her about why. And I think that was a large part of it. Was introduced in 19. We're trying very hard to support that larger state fund. Our effort there was to get private insurance coverage to cover mental health, since we couldn't get any public monies, to meet Republican policy to the extent that it relied on private insurance, but it was bad to the extent that it mandated it, and that was the reason it failed. To get direct funding by getting a ballot initiative to put a tax on alcohol, the proceeds of which would be well enough, collected enough money, got enough signatures, did well enough on the ballot to make political presence stronger, better known than it had been before, but not enough to pass it, so we didn't get any money out of it. But able to do a lot of that because of work that had gone on in those years around the state where we're going, and it doesn't deal with the unmet need and how we're going to address them year after year. So we finally got some state legislation passed that set up a planning council that was required to report back to the state on unmet need. Met, deal with. They had to because of the legislation. So we got king of the part of the legislation to what we had been. Before Dick resigned, he had spring. I had been the regional director another year in San Fernando after he took over. Then I had 9 months in San Gabriel. Then I was put in a central office job that was called Community Support and Residential Services, and while I was doing that, I did, not too long after harassment.
Regrets about leaving?
No, I didn't. No, I did not. Finalist from Los Angeles. The part about being part of the health department in San Diego was that their health services, environmental health, met regularly and had good policy discussions, so that it was a very healthy group together, and a lot of sharing and concern about the various aspects of health. Much better run than the health department had been when it was in Los Angeles, at least. Contributing to about programs, and they talk to one another. Whereas if it's a facility, you're more likely to get into turf problems. Mm-hmm. And LA was organized around the hospitals, and back and forth over the years, from focusing on the hospitals to focusing on the clinics, but almost always seeming to focus on that kind of with it, the way we were and could never easily benefit from the knowledge growth that happened over the years, and that's been able to get our block grant money should be used for mental health services. So it ends up that the mental health providers who are trying to be forward-thinking and recognizing the real problems of multiple disorders are ending up spending all the mental health money. So I do blame Harry for that piece of our history, that he didn't sideline that should be mentioned. The qualities of the mental finally used to approve the county plan money. Said we won't give the money to the county until it happened the same year. Your discussions cooperatively, but always were. Them have
that's easily arranged. Because while I listened to make sure that there was no overlap. This is resumption of the interview with Areta Crowell on her experiences in the Department of Mental Health. Today is
November 6th, 2000.
November 6th, 2000. Right, why don't we just start?
Okay. Would you like me to start with San Diego?
That would be very good, because you had just finished up at Los Angeles.
Just finished. All right. Well, moving to San Diego was different in a number of ways. The mental health program.
Unless I touched something wrong. I only wanted to turn the volume up so that I had to be sure of that. All right, it seems to be operating.
San Diego's political environment was far more conservative than Los Angeles. They had not started a mental health program until they were required by state law to do so. And during the 60s and 70s, when San Francisco was building a network of community mental health centers using federal money, and California had Los Angeles had finally started, I think I must have talked about that on the last one, to get the La Puente Community Mental Health Center from the government, and then there were a number of private ones established in Los Angeles. Nobody in San Diego was using the federal Community Mental Health Center money at all. In fact, they had a very deliberate policy. Their founding mental health director had been there, a psychiatrist named Dr. Stadell, had been the director from the founding until, early 80s, I guess. And he did not believe in using federal money. And I think that reflected the general governmental attitude in San Diego, that you used as little government money as possible. So there were no community mental health centers. There were community mental health clinics spread around the county, and one county-operated inpatient unit that was run in conjunction with the University of San Diego, UC San Diego. San Diego had essentially sold its public hospital system to the university, as did Orange County, unlike Los Angeles County. And your history project might well want to do a study of the counties that sold their county hospitals and what happened, and how that history then became very different in Los Angeles versus the counties that got rid of their hospitals.
That's worth looking into.
It's a real fascinating subject. But in San Diego, the part that the county did not give up, and I believe it was because the university wasn't keen to have it, was the psychiatric inpatient program. That program was run by and through the Department of Health Services and the mental health branch of that department. So I, for the first time, was in charge of a hospital as well as community programs, and it wasn't just contracting with the hospital services. They were in my direct line of administration. They had just authorized building a new hospital, and that was being built adjacent to the headquarters of the health administration on Rosecrans, and that's where the mental health administration was in the new hospital.
And this was to be a public hospital.
Public hospital operated by the county. And they had done a very nice job of getting architects and getting it to look like a really good program. And they had a wonderful hospital administrator named Karen Lee Robinson, who had come into that job at the time that San Diego made 60 Minutes as the only psychiatric hospital in the country that had lost its Medicare certification. That's another whole long political story that I think their losing that certification was unmerited relative to lots of others that should have. I don't think they were that much worse, but there had been a couple of deaths in the hospital, and they got investigated, and 60 Minutes came, and that just fed into this political spiral that they were visible and they had to be punished. There were deaths in plenty of other hospitals that didn't result in decertification, but it meant that the whole thing was very politically sensitive. They had made a major mistake, and that was that they licensed the hospital as a freestanding hospital, which meant it was not eligible for Medicaid funding. To get Medicaid money for adult patients, you had to be part of a general hospital. And they had been part of a general hospital, but they severed that tie and then built a new freestanding one, so we could not get Medi-Cal revenue.
In advance?
They should have. It was known. It was the fact. Had I been there 2 years earlier, I might have been able to stop that, but I wasn't. Might have taken 3 or 4 to stop it early enough in its tracks to get that connection reestablished. But anyway, it was too late by that time. Really, really sad when you see people make those kinds of big public mistakes. Anyway, we worked real hard at establishing credibility and connecting the system and getting the emergency room to work with the rest. And it's many ways it was like the Los Angeles problems, but the nice thing was it was so much smaller that you had a sense that you could know everybody and know what was going on and really understand the dynamics and have an impact on it. And we did a lot of system change. We published some nice plans and work, and we actually got a competitive NIMH grant for services to homeless mentally ill adults, one of 8 in the country, and we were very proud of getting that one. But that had its own share of politics of why we were successful, I am sure, because Lou Judd, who had been the chair of the Department of Psychiatry at UCSD, was the director of the NIMH for a while, and he had a colleague from UCSD that he brought back to Washington to work with him, and the colleague's wife was second in command in the San Diego City Housing Authority. And she was, I guess she didn't know my friend and colleague Irene Levine, but she got to work with Irene. Irene was head of the homeless program for NIMH. And Irene and this woman, Betty Morris, worked together, and Irene picked Betty's brains to learn about housing and homeless mentally ill, and out of that they created a program, and a research proposal and RFP went out for testing theories about services to homeless mentally ill adults. The main thing that they were interested in was showing the impact of having housing available for persons. So the city had to contribute Section 8 housing certificates to the project. And they did because of Betsy. Because Betsy came back to San Diego and had learned enough about it, and so she was able to sell the city. And with us together, we were able to sell the county on applying for this and getting the money for this project. And our thesis was that you could take homeless people off the streets and put them into housing directly if they had enough support and case management, and then options created for them to develop employment possibilities and so on. And we had a very good success rate. It was about 68% success with homeless.
High.
It was very high. And it would have been higher. We got almost as good with our control group as we did with the experimental group, because the contract agency that did the experimental, which was intensive, flexible, wraparound case management, didn't do it as well as they could have.
Mm-hmm.
They didn't have that charismatic leadership that the leader of our county case management unit, the social work program, was determined to show that they could do just as good a job as these guys who had more money and more options on what they were doing. And she made sure that her staff did. It was a very good lesson on how to get your leadership hooked into doing the right kind of changes. So we worked hard on the homeless people in downtown San Diego. They had an awful lot of problems there. And
was a substantial proportion of them mentally ill, as they are in Los Angeles?
Yes. San Diego attracted homeless mentally ill individuals the way all the coastal counties do in California. The weather, people can survive outside. They can do recycling and things like that. They can find ways to support themselves if they want to be cut off from all other supports. San Diego was tougher on their homeless people than a lot of Los Angeles County, but depended. That varied. We worked with the sheriffs and we worked with the city police chief, to try to help them find ways to help the people instead of just putting them in jail. I'm going to say this.
I apologize for that.
All right, that's all right. What was the other, key stuff down there? That grant was important. The homeless outreach. We had cuts to take in San Diego at the same time that Los Angeles was taking cuts while I was gone, and it was very rough because San Diego had far less resources per capita than Los Angeles. One of the ways that had happened, if you took it on a straight dollar value of the available services, they had not used the state hospital very much. Los Angeles used the state hospitals a lot. There is a literature that implies that distance from the state hospital is a major factor in the utilization, not need. And certainly the San Diego experience reinforced that attitude. After the Letterman-Petra-Short Act was passed and the county's budgets were consolidated in the sense that the state hospital dollars were added to the dollars of the local program to say these are the resources you have. In theory, you could move those dollars around, but in fact you could not, and I think I talked about that some in the earlier day. San Diego had 71 state hospital beds when I went there for a population of over 2 million, whereas Los Angeles had well over 1,000, I think 1,070 some, as a matter of fact. Mm-hmm. So the dollar value of those 1,070 beds in Los Angeles had kept escalating as the state had moved to get accreditation for the state hospitals, as they moved to comply with all of the standards that were reasonable for a hospital. The dollar value of what Los Angeles had doubled or tripled during that 2 decades practically. So that when you look at the grand total, Los Angeles then moved up to be slightly above the average for the state for total dollars per capita. San Diego's local resources were proportionately less than Los Angeles's, but the state hospital was so drastically less. And at that time, you couldn't do anything about it. I mean, you couldn't add to your state hospital resources no matter what you said. The other counties objected. Mm-hmm. San Diego filed a lawsuit against the state to get its fair share of resources. It's a logical thing to do. They were so far down that why can't we have our share? Give us our share of the state hospital and local dollars. The other counties that were heavy state hospital users, including Los Angeles, banded together to fight against the San Diego lawsuit. So while I was director in San Diego, Dick Elpers, my good friend and previous director in Los Angeles County, was a witness for Los Angeles against San Diego. The premise for all those counties
was it to protect money for
Los Angeles? It
was
to protect money for the other counties so they wouldn't lose it, because it wasn't an environment in which you could add to the state general fund in order to accomplish this goal. Nobody ever would have minded had they been able to do that.
Yeah.
But it was already so well established that we weren't going to add resources for mental health. So they all said, yeah, well, you get more, we'll get less. No, thank you. We'll fight like crazy to prevent that. So that was another major thing that happened while I was in San Diego.
I gather that San Diego did not win out.
The judge, who was a local judge and very sympathetic, ended up basically saying they were right in principle, but she was not going to order the state to do anything about it. When realignment passed in 1991, a special deal was hammered out with the County Supervisors Association and the legislature, so that San Diego, there's a formula that's quite interesting, and San Diego gets more money after realignment. How it works is this. Realignment was passed with a revenue base in the county programs. That was what the state budget had been. It was to be replaced by sales tax. Dollar for dollar was the theory. But the legislation specified it in such a way that if the sales tax didn't equal what had been the appropriation, then you got that share of the sales tax. So it went on a share of the sales tax. Well, as you will remember, the year after that passed, the economy tanked and the sales tax went way down. So the counties did not get what they were expecting, even as that baseline. So the deal was that as soon as the sales tax enabled all the counties to get back up to their baseline, then after that, San Diego would get a greater share, and some of the other counties that were significantly below equity would also get a greater share of the growth before the growth would start to be spread around among all the counties. I mean, it wasn't a before, it was done on the same time frame, so that when you got beyond the baseline, everybody would get something, but they would get more. So that was the benefit of that lawsuit. They made real clear that they were serious about it. But again, they had not taken advantage, just like Los Angeles had not taken enough advantage of the Federal Community Mental Health Centers Act when it was available to help raise the whole water level. Those are some of the main things about San Diego. One of the nicest things for me was that before I left, they asked and got permission to name our outreach center. It's an outpatient and outreach program that was in Skid Row for me. So there's a Areta Crowell Center in San Diego, which is kind of fun. When they first asked me, I said, I don't know, that usually happens for people who are dead. I'm not sure I'm glad to do that. I was going to tell you a little bit about one other political thing, and that was taking the cuts. The resources so low, what do you do? Well, the medical director of our hospital, by the time we get to this stage, the hospital had been opened, and it was a wonderful hospital and doing a great job and all kinds of nice things about that. But he came up with the idea, he was concerned that it was divided in 3 major units in the hospital, two of them serving as acute wards, and the third one serving for specialized geropsychiatric unit. And it was supposed to be acute, but because of the difficulties of finding placement, often that did not turn out to be the case. They were much more long-term maintenance than acute care. And the same happened in the adult acute units. We accumulated patients who could not be placed and were really on maintenance rather than high acuity that needed the acute hospital service. I did manage one resource increment for San Diego while I was there, and I used all the political connections I could, and that was to get a 100-bed skilled nursing facility, a dedicated psychiatric skilled nursing facility funded out of the state, as they had to, I can't even remember what they had to change. They had, they got some new skilled nursing money somehow, and an expansion of capacity, unrelated to the rest of the appropriations. But we got 100 beds in San Diego because I really worked with buddies and friends and used everything I could. So that raised the resource level some. And we were able to take that major cut just before I left by converting the hospital so that instead of being 99 acute beds, 1/3 was converted to skilled nursing facility where we could get Medicaid dollars. 1/3 was acute, and the geropsychiatric unit it was able to get Medi-Cal dollars anyway, but we were able to increase the efficiency of its use by sharing that Medicaid. So we cut the $5 million worth that we had to cut. We didn't cut any beds. What we really did was redesignate them to be what they had functionally become, to be able to get some more revenue and make some cuts in expenditure, because you don't spend as much on a nursing facility bed as you do on an acute bed. You have to keep your license. You keep the nursing staff there whether they're being used or not. So it was a good compromise, and that physician really came up with the idea. I would not have thought I wouldn't have thought it could, but he was there. He was the medical director and said, I know this can work. This is what we're doing. Let's do it this way. The politics were so intense against doing that. That was a proposal that we worked out in the summer of 91. Budget cut announcement came in May or June. We worked that out over the summer. We presented it to the board in September. They had so much opposition from the court and the emergency room doctors who said this won't work. Even they were sure, even though they were in the same hospital, they couldn't get it through their heads that that's what was happening within the hospital and understand that they would have the same flow of patients from the emergency room as they had before, because there would be just as many acute beds available. Sometimes you wonder where people are in terms of system understanding.
Machen was still governor then, wasn't he?
Yeah. Yeah. Now, anyway, the upshot was the board wouldn't approve the plan in September. They ordered some more studies and some more stuff and requested me to come back. Must have been again in October, because it was before I accepted this job. I knew I had to be back at the board the end of January to bring the plan back. I wasn't going to change the plan, but they were kind of asking me, see what you can do. Well, it wasn't anyway. That was all happening at the time that I was approached to come back to Los Angeles. But the board approved that plan on basically my last day in San Diego when they implemented it. And this medical director and I kept in touch and said it worked. Did fine. So people have to use the dollars the best way they can. I mean, the judges were trying to get more money into the system. They thought surely somehow they could get it if they just hollered loud enough. Doctors tend to do that a lot. I don't know whether you've noticed that, but I have. We had the same kind of situation developed in Los Angeles later, and I'll get to that, I guess, before too long. But it was exactly the same kind of thing. The USC had developed a habit of making as big a crisis out of everything as they could. Because they figured that way sooner or later somebody would pay attention and give them some more money. And it just wasn't in the cards for so many of those years. There just wasn't money that anybody could manufacture. I knew people well enough to know that if they could, they would. They weren't giving us less than most other programs. You know, I mean, it was just crazy, but that's another whole thing. Anyway, the upshot was I had, during that summer, while we were going through this fight in San Diego, I had sent in an application for the LA directorship when it was vacant. And then it got down to the interviews, and I said, I don't want to go through the LA politics again. Forget it. This is bad enough, but at least I can live with San Diego politics. I know these people. They know me very well now. We'll survive. And so I withdrew. And I started getting calls from people about the finalists for the job, and there were several that I said, no, I think that person could do it just fine. You know, Dick Gilpert's wife, Bev Abbott, who was director of San Mateo, I said, Bev could do that. She graduated from Long Beach. She trained at Metro. She knows Los Angeles some, and she certainly knows it from... One county mental health director knows all the things that every county needs to know. You just have to. So there's not that translation. And it's just a matter of size, and she's aware of the size, and she certainly should. She's a good administrator. I think she could do it. So I pushed hard. People kept coming back to me and saying, they're not going to appoint her. And they didn't really like the other finalists, and wouldn't I reconsider? Finally, Ed Edelman called me, and so I said, okay, if you really want this, then you have to support me. You have to not put us through the ropes in terms of cutting programs and everything. Ed was quite proud when he retired. He would say to people, I got a special deal because I got the CAO to write to Areta that she would not have to go through cuts. Well, the letter actually said, we'll do our best, but you know that we don't have, we can't guarantee what the financial situation is going to be. And anyway, Dixon treated me okay. I couldn't argue. He treated the program fine when I was there. But that was Ed on the phone, several times, getting me to agree to come back and be interviewed. And so that was how that all happened. It was about Thanksgiving of '91, and I couldn't come right away because I had committed to this supervisor's hearing in San Diego the end of January, and I felt it was like my moral obligation. I had to see that thing through. Then I could start something else. So I did. I came to LA with the idea of, what do you do to make some changes? Everything I knew from my old buddies and other people in the community was that the department was extremely demoralized because of the large number of cuts that had been forced on the department, and which Roberto had basically taken from closing community programs. And that meant that proportionately out of the budget, there was still a lot more in the state hospital than there had been, certainly. And compared with San Diego, and knowing that we were able to survive as well as we were in San Diego, I was comfortable that we could push the system to survive with less hospital beds if we weren't going to have money to expand things, and that in fact over-reliance on hospital beds had been unhealthy for the whole system. It was pushing people to not try to keep people in the community because you've got a back door handy. You can send them to the hospital, and you can't help human nature. People are going to do what's easiest if they can. You let them leave that door open. It's easiest. It's a lot easier. Out of sight, out of mind. So my thought had been, and with realignment, that was the other key factor.
This is cassette number 2, continuing the interview with Areta Crowell.
Okay. We were talking about the challenge in coming to Los Angeles of trying to restore some sense of hope and optimism to the mental health system in the county. There was a great deal of dissatisfaction with the system from the public and the supervisors, but the people inside it were very demoralized, and there was just a general sense of depression in the whole system. And so the question was, what can we do to make a difference? How can we make it better when we don't have nearly enough resources? We know we don't have enough resources, and we had no prospect of getting more resources. So because I had known how San Diego survived with a fraction of the per capita available resources that Los Angeles had, I had some confidence that by being able to move resources around, which realignment permitted, we could make some positive changes. So I started with the families and the clients and the constituents to talk about this as a concept, moving money from state hospitals into community programs. But I was very specific that what I thought we needed in the community programs was to have targeted programs where people would be enrolled as members of a program, and that then you would have accountability for that person, for what happened to them over time. That was the key concept, to maintain accountability over the duration of someone's disability and illness, and not just on an episodic basis. LA had, as San Diego had pockets of quality, but what was needed was to make the longitudinal accountability a reality. We developed a program that ultimately became called Partners as a way of implementing that change, and it was funded originally by reducing state hospital beds so that we reduced the amount of money that was needed there, and wrote up a very detailed specification for the community-based program that was to replace the state hospital beds, and we had 500 enrollees budgeted in that program for the first go-round. Now, 500 is a small number in terms of Los Angeles County's population of persons with severe and persistent mental illness, but it was still a sizable enough group, and it was quite a challenge to get that organized and operating. But we did that with support from all of the constituent groups, and that was vital to make a change of that magnitude. It involved cutting a couple hundred state hospital beds. It meant that we could serve more people overall, because we moved from 200 state hospital beds to 500 in the community with intensive wraparound services. We drew, in writing up the specifications for that program, we drew from the experience of the Village in Long Beach, which had been funded by the state as an AB 3777 Systems of Care for Adults project grant. They had developed and done very well. There were other similar programs around the country, and we tried to pull those things together and write up a good description. It was more prescriptive as an RFP than most of them are, because we didn't have the confidence that everybody would understand what we were getting at. And before the responses to the RFP were due in, we had a very large conference focusing on rehabilitation. I know that at that conference we introduced again for people Bob Lieberman's concepts of psychiatric rehabilitation and his research and experience of how with enough support and training you could accomplish things. We had people from San Diego talking about the homeless, mentally ill adult project that we had from federally funded and what we had learned there. We had some other national research described. And we talked about what we wanted in this program, where I really wanted to emphasize client empowerment and active participation in their treatment programs and plans. That's not radical at all today. It wasn't even radical then, but it was certainly not mainstream and certainly not widely accepted or practiced in Los Angeles County, and that was the challenge. How do you set the direction moving? You need to get a critical mass that accepts all the concepts that we wrote into that plan and that are, I think, much more accepted today than they were 10 years ago. So that was the approach we took. Some of the providers of drug and alcohol programs came to those conferences because I also have been very aware of the large number of persons in that classification of high-need people who have substance abuse problems as well as mental illness, and we'll go on for great length of the causality or whatever, but it's still a reality that they have both kinds of problems. And I was very interested in these programs not turning people away just because they had a substance abuse problem, but they would be able to deal with that as well. And I know the word I got back from the substance abuse community was they had always talked social model recovery, but they'd never heard anybody talk it as much as I did in that day as we presented all of this. So people knew there was a change, and it was being circulated, I think, around the community as people talked about what we were trying to do. So getting the partners off the ground was like a first step of system change, even while we were doing other training and other work on system relationships and issues. So that was the major one. Another one was to try to upgrade all of the county facilities and treat people with dignity and respect. We had the most rotten facilities. And as we managed to get more Medi-Cal revenue into the system and other things, we put a fair amount of it into upgrading facilities, and got into a big fight with the chief administrative officer at that time one year when we had, it was before Supervisor Edelman retired, we had a program we were trying to move into new space and the county budget was in bad shape, and she was very worried and trying to get the supervisors to rein in their expenditures and so on. So she recommended against approving our request for a lease in this new facility. And we got the community out and we protested, and the board didn't want to turn it down. They needed us to help them find a way so they could not turn it down, so we met the technical things that they wanted. But I explained to all of them we would be cutting more state hospital beds before we would cut any of these community programs, so having a decent place for them was an important part of that. Get it as part of a system. She didn't get it that way. That was Sally Reed, was the CAO at that time, and she didn't like that at all. But Ed, again, that was another one of Ed's triumphs when he, after he retired, would talk about what had gone on. Beating the CAO on that one tickled him a lot. A couple of it. Every one of those was another fight with the community around NIMBYism. We never opened a facility that we didn't have a lot of problems with just getting them accepted, and through all the hassles. And Hollywood, we had to agree to a zoning hearing a year after the thing was opened in order to open it even. And the churches, almost always the churches, have been involved in opposing us, I'm sorry to say. It's common. So one theme was the partners, the integrated, flexible wraparound, targeted services. The second was improving the facilities. The third was honesty in dealings with everybody. The fourth was letting everybody know what was going on all the time, trying to have no secrets and no hidden agenda, and that everybody would buy into the agenda. So we would all be together. That was one of the things I think I've learned over my career, was that if you when you have a small targeted community like mental health, if they fight among themselves, it's easy for the rest of the world to dismiss them, because they just say, well, you can't agree, so we won't do anything, and you never get support. So you've got to speak with one voice. That was the California Coalition experience, I think, much as anything, that really reinforced those needs. What else is important? Since we put so much down in the history book now, I think that there's no point duplicating a lot of that. We obviously had an ongoing concern about having enough bilingual, bicultural service providers, and that has had a disappointing history, that we did not have enough, couldn't get enough money to support people in training. We tried some creative things like help employees to get some scholarship money from the county so they could work part-time on degrees. Did some of that, but it was not nearly as feasible as it is today. That's one of the nice changes, that as more money has come in, that is one track that the county can support. We had legislation developed that came out of the Mental Health Association in Los Angeles, had called together a group and some of the LA County people and other people around, trying to figure out this whole human resource issue. And they'd come up with the idea of getting kids in high school interested in human service and treating them like candy stripers and giving them, jobs and money and support and mentoring and nurturing and everything it would take to get them to pick that career and stick with it. And it was a wonderfully developed program concept, but nobody knew how to fund it because we were so short of services. People were afraid to take money out of service to do something like that. You were subject to so much criticism for cutting any available service when you were so short. Polanco introduced legislation to fund that program using professional fees, social work, psychologist, and physician fees. Well, the physicians at large objected. They didn't want to pay for the mental health professions, and the psychiatrists, they had no way to tab the psychiatrists as a body because they're not maintained as such in the California licensure.
I didn't realize that.
Yeah. If they belong to the Psychiatric Association, that's one thing, but a lot of psychiatrists don't. So that was kind of difficult. So they didn't support it. The psychologists supported it. Now, I was very active in the California Psychological Association all that time, and quite a few of us from public sector mental health were involved. And the state Psychological Association was good on a lot of ways. They were very supportive of the public mental health concerns, and they supported that, to tax themselves to help with the professional development. The social workers didn't support it. So without any support, that just died. The psychologists weren't enough to carry it.
I wonder why that would be, because
they said, why should we, out of our licensure, pay for what is a whole community's responsibility? Mm-hmm. I mean, it's a fine argument, but it's not. It's guaranteed to make something not work. Mm-hmm. In a time when people are absolutely resisting raising your taxes for anything, and there wasn't enough money to spread. I mean, it sounded good, but it meant that you couldn't do it. So now that plan has resurrected and is being implemented now, not by taxing professions to pay for it, but in a much smaller way. The Mental Health Association in Los Angeles County has started what they call the Academy in 2 schools now, one in Long Beach and another one in San Gabriel Valley somewhere, I forget where, if I knew. And they are getting kids into the program. It's like a magnet school to do human service and giving them some exposure in human service jobs, not just mental health, but human service, with a big emphasis on minority kids so that they will have money coming in, people talking to their families and them about how this is a good career path, what to do, and so on. So I'm quite excited that that's finally happening. And the other things happening too. Welfare reform is opening up a lot of possibilities for people in human service, and the welfare department is just doing an enormous amount of supporting people in their career goals out of the welfare to work money. It's spinning off into those kinds of things. Lynn Bayer was telling me last week that they have huge numbers of employees who don't even have high school degrees, so they're helping them get GEDs and stuff like that. So just raising that whole level of accomplishment and possibility for people is exciting. The other big area of development in Los Angeles while I was director was the expansion of children's system of care. There was no implementation of the system of care in Los Angeles when I came in '92. We worked for and got kids system of care funding. I don't remember the year. It will be in the book. I think it was 94, 95. We brought Randy Feldman down from Ventura to talk about their experiences. The Children's Roundtable was very supportive of trying to get this moving. So we had, again, the whole community was behind it and supported it and pushed it. And we were able to get money to start in 2 small areas, just for starters, East Los Angeles and Antelope Valley, and they were picked because of the highest number of SCD referrals coming in, I think, was the reason. Again, it was targeted to be as logical as possible, pick something, and you always have to balance the logic and the politics. With 5 supervisorial districts, you very often end up doing things in 5 places that you might not choose those 5 places, but we've been able to keep pretty consistently in terms of priorities and not having to break it down too far because of the politics. Partners, for instance, we did have 1 in each supervisorial district. 5 programs. Well, actually, we started with 6 programs.
Probably we won't have additional members of the Board of Supervisors, and that will be good.
I can't get enthused about more members of the board because the larger number of the city council isn't all that functional.
That's right.
You get too many
With a
fights.
smaller area for each than the supervisors.
So it will be interesting to see. They've never succeeded before. We have 2 of the supervisors putting their money into that, though, this year. So we'll see. Anyway, yes, it would make everything more well, I don't know. It might not, because you can't always do 9 of everything. So maybe you wouldn't be as pushed to do 1 of everything.
Yeah.
But you could sure get hogtied if you only could do something in a couple of areas and the others decided to get together against it. You'd never move it. It could make more gridlock. Anyway, so the children's system of care is something that went really well, and we worked hard to get a lot of creative things going there. The EPSDT, again, a lot that I did was part of the statewide mental health directors working with the state to try to move things forward. So a lot of that happened. As far as Los Angeles County, the other, I guess, major point in looking at our history was that mine was the only administration that had non-stop disaster grants to administer almost throughout my entire tenure. I came at the end of January in 92. In April, the Rodney King verdict came and the riots that followed. Civil unrest. We felt that it was indeed a sufficiently traumatic experience for the whole community that we should apply for, and we did, and we got federal disaster assistance money to provide counseling and support. And we brought people together who were experts in disaster response, and people in this case who were expert in ethnic relationships as well, tried to guide what we did. And we did, I think, some creative things. But that grant had not terminated before we had fires in Malibu and in the hills up here by Pasadena, followed by floods, both of those labeled as disasters, and for which, in order to make services available to people, we were expected to apply for and get the federal monies, and we did. And then you have to administer them. So you had all that happening, plus continued reductions in budget, plus our efforts to streamline and reorganize and make the department more efficient and effective and bring in quality improvement procedures. And then we had the earthquake in 94.
It was a non-stop.
It was non-stop. Non-stop. I was extremely fortunate to have Kathleen Snook as my chief deputy. When I was offered the job in L.A., I called Kathleen and asked her if she would consider coming back to the Department of Mental Health. She had been the Director of Administrative Services, which was not a chief deputy, but she functioned rather like that. When Dick Elpers was director, he had Hal Mayward as his medical director and Kathleen as his administrative services director, and the three of them did all the administrative things together that when Kathleen came back as chief deputy, she and I did together pretty much, although we tried very hard to include our medical director as much as possible in that trio, and everyone else reported then to us. Kathleen was a very hard worker, a very knowledgeable and tough administrator with long county history. She knew everybody and everything in the county, including she was very good friends with the CAO who was there when I came in. And I asked him for permission to hire her away from where he had just put her, where he had another problem that he was trying to solve, but he agreed. That was part of his deal with me, was, okay, Kathleen can come do that. I don't think we could have maintained credibility if I hadn't had her throughout that enormous administrative stress. She was a really tough right hand and could cut through and get things done with the CAO's office. That somebody who had to learn all that would you'll lose credibility if you can't do things fairly quickly. And we had enough problems, but not nearly the problems that seem to be developing now. Even though they have the money in the department now, they're having a lot more oversight problems and things, so that stuff's taking longer to do. Kathleen fought for autonomy of the department.
Is she still there?
No. She retired before I did. I knew when she was going to retire, and I did decide to stay on after she left long enough to try to make a transition before a new director would have to come in. I had thought I might appoint a chief deputy in between, decided that it probably would be better to leave that for the next person. I'm not sure that was the right decision or not, but anyway, that was my thinking. That's what I did. So I worked without a chief deputy from did she retire in September until I left the following March. So we went through one budget cycle. But she did an enormous amount. Anyway, we streamlined, cut down administration. One of the first things I did was significantly reduce what had been a contract audit compliance unit and take clinical positions out of administration and free them up to be moved to do some clinical work. And we targeted work at LAC USC Med Center, and I'll tell you why. Before I came back, after I'd accepted the job, but before I came back, there were quite a few articles in the paper about the emergency rooms at USC, and specifically the psychiatric emergency rooms. They were closed a great deal of the time, and that meant the police couldn't bring emergencies to that hospital. They had to traipse all over the county looking for another emergency room to take somebody to.
Why were they closed?
They said they were closed because they didn't have resources, they didn't have places to put people, so they were crowded. The emergency room was crowded, they couldn't admit people. This was what I meant when I said we would talk about the doctors circling the wagons and saying we won't do, as an effort to make a point. At the same time as that was happening, there was a scandal in the medical emergency room of psychiatric patients being left there in restraints too long, and one patient died, or if it didn't, I think one patient died after staying too long in restraints in the medical ER. So there was a big squabble between the medical ER and the psych ER, because psych wasn't taking them, so they'd end up in the police would do their best to get rid of the person. That's, again, human nature. They just wanted to dump the problem and get on with their jobs, because they have always seen psychiatric emergencies as not their job. It doesn't matter that when you have an emergency you call 911 and that's the system. They don't care. And you understand, they think their job is they're trained to deal with crime, and they're trained to deal with using their guns and doing all that kind of stuff, whether that's good or bad, but that's easier. It's their job. They don't know how to handle psychiatric patients. So that was going on, and I went to Dick Lamb was the head of the emergency room at the time. Now, Dick has a great track record of writing about community psychiatry. So I expected Dick to be rather sympathetic when I came and said, Dick, we've had this really great experience in San Diego with revamping the emergency room and making sure that we had a system so that you could move people out of the emergency room and have a place to put them, and you could use some support. One of the things we did in San Diego was we had some targeted case management to work with the high users of the ER. Called them the frequent flyer group, and we assigned them to a smaller case management. I forgot to mention that, but that was one of the other experimental things I did that worked extremely well. We got a bunch of real problem patients into this intensive case management that was very targeted, very, very personally designed for each one. And they had a wonderful advisory group with family members and consumers and the staff. They would bring the client's case story into that advisory group and go over it in detail to get ideas of what to do for the person. Mm-hmm. And that advisory group knew them all by pseudonym, not by real name. Well, it was a small enough community that after a while, I'm sure some of them knew who they were. But anyway, they full of good ideas. The social worker who ran that program got a lot of publishing and a lot of visibility around California and the country because of that program. He did a wonderful job on it. He talked about how he didn't believe it would work beforehand, and when I insisted that he do all these things like getting the clients involved and getting the advisory group, so anyway, it worked. So I went to Dick Lamb saying we would take these resources and direct them to him so that he could have this same kind of an intensive case management program to work with his ER. He said, in effect, thanks, but no thanks. He wasn't the least bit interested. We did end up, however, sending some resources over to work with the emergency room. Not quite the way we had it in San Diego at all, but at least it did give them more resources so that they could move people out of the ER faster, and directives to the rest of the system. Give priority to these individuals. You must be able to make an appointment in the clinic right after if they're calling you from one of these people, so they don't have to keep them in the ER for long periods of time. I concluded, however, that stuff was going slowly enough and they were still doing closing the ER and stuff like that. I went to Bob Gates, who was then the head of the Department of Health Services, and said, Bob, I think you really need to partner with me in this. We've got to make some changes. Because as long as the doctors think that by making it more difficult they're going to get more resources, they're giving both of us black eyes, mm-hmm. that we can't run this system. And, where were we going to get the money? They were holding out. Well, I was already cutting my admin to give more resources to help. I wasn't going to do any more. I didn't have any more that I could do at that time. So Bob agreed with me, and we went to Vandermeulen and we talked about the problems.
You went to
Vandermeulen.
Oh, Vandermeulen.
So we got some changes there, and things did improve.
Mm-hmm.
Mm-hmm. A lot. But then the next round of things that happened with the medical system was we had another big cut to take as part of the Medi-Cal problems of the Department of Health Services. They got a waiver. They had to cut their inpatient, but they still had cuts to make. And they proposed to cut all of the psychiatric programs out of their hospitals.
That's pretty bizarre.
Yeah, it was pretty bizarre. It was clearly political. That was the summer that they had a Blue Ribbon Task Force meeting all summer to talk about how the budget was going to be resolved with it's the health service budget, basically. It wasn't DMH budget per se, but DHS said they had been subsidizing the beds and they were going to stop subsidizing them, and they said they spent, I forget the numbers, I'd have to go back to the documents, and some of them are in the history book.
Mm-hmm. I'll check it out.
They claimed that they were spending, let's say 50% more on the beds than I was paying. Now, by the time this happened, we were into the Medi-Cal consolidation, and we had been administering the fee-for-service psychiatric beds. That was the first stage of consolidation, was we got the responsibility for admission and funding for the use of psychiatric inpatient beds, and we had negotiated contracts with all the hospitals at a rate that was 50% of the rate that the health services claimed for the beds, acute hospital services. So, since they were going to play hardball, I decided I had to play hardball too, and I said, fine, you close your units, and we'll contract, because there are plenty of beds in the community in these private hospitals, we'll contract with them for all the patients, because that we could do within our budget.
They weren't happy about that either.
Yeah, they weren't happy about that. It ended up in a compromise. They cut some of their beds. We did it at a way that we calculated very carefully that if they would bring their length of stay down to the length of stay that was the average in the community, then there would be no fewer people who would need to be treated than had been treated before. And that was, we worked very, very hard, because I do believe that the county hospitals took people who were more difficult, more physical problems probably than the freestanding psychiatric hospitals could do. And they were more accustomed to all of that. But at the same time, from the point of view of system efficiency, their problems had to do with not having learned and worked with the community programs as well as they should have, and having too much turnover. That's part of the downside of the academic training program, is you get people turning over all the time. That was one of the reasons why the crisis residential treatment beds never got off the ground in Los Angeles County. We were able to get funding for a small number when the Bates bill was passed in 1979 or thereabouts.
Which bill?
Bates bill for it was community residential treatment system was the thing, and crisis beds. We ended up with, I think, 36 six-bed programs. They were modeled after San Francisco, where they had been 12 to 16 bed programs that Steve Fields had started and modeled, and he was close to Bates in the Bay Area, and that was how the Bates legislation came through. We knew we didn't have the stock of bigger old housing that you could put 12 beds into, and especially we didn't have the zoning openness to that because of the conservative nature in Southern California. San Diego, however, even though they're conservative, managed to get 5 of those programs going, one in each of their 5 health districts, and about 12 beds in each. And so they had 60 beds. San Diego had 60 crisis residential treatment beds and 60 acute hospital beds in the county system, not counting before Medi-Cal consolidation what the Medi-Cal beds would take, and there were very few of those. Other hospitals didn't want the county patients, and they, even though they could be paid under Medicaid, they just didn't do it. So 60-60. And that ER loved the crisis beds, used them, knew how to, said they would die if we cut the crisis beds. They just couldn't cope. LA never used them. Well, I think it had to do with critical mass and the turnover in the emergency rooms. The county hospital in San Diego was largely a stable medical force. Yes, they had some residents, but they were not the key human resource in the emergency room the way they are in the emergency rooms in the hospitals in Los Angeles. So I think that had a lot to do with it. Anyway, that kind of problem in their ERs, we finally came up with a compromise and funded some beds in each of the hospitals based on their length of stay and the number of cases and what we thought they should be able to live with. And the other thing there was that Milt Miller had worked over the years to get the performance at Harbor UCLA more in line with national norms. So he had a shorter length of stay than the other county hospitals. So that was part of the deal. You bring your length of stay down. We know it can be done. If Harbor can do it, you can do it. So that was what we worked out. That was probably the most traumatic time of my directorship in terms of trying to make things work so that nobody would fall through the cracks and we wouldn't have any crises and tragedies, because that just haunted me, that the hospitals would dig in their heels and try to create another tragedy. I mean, never conscious. Well, I wouldn't even say it, maybe not consciously, but it could so easily happen. In fact, I guess the whole time you're a mental health director, you read the paper every morning just looking to see if there's a tragedy that is on your watch. It's the wonderful thing not to have to look at the paper and worry anymore.
The advantage of retirement.
Yes, that's right.
It could be stopped.
I think that's a good idea. I was just going to say, I'm running out of breath and
you need
steam.
something to drink.
That just meant so much to me.
Well, that was really very good presentation, and our group was very enthusiastic. We have a tape of that.
That probably is a good history piece, because I did talk a lot about this, and perhaps a more organized way that day.
I think I will remember to get it pulled out, because right now we have somebody who is able to transcribe, and I think I'll
that would be good. That would go well with this, yes. But anyway, it felt wonderful, because you never know when you're buried in it. You try to get the feedback and the data so you can correct your course. We expanded the Partners program. That was one of the things we were able to do. Expanded it. Second year, we got the contractors to expand by 10% without any more money. And then the year after that, we got more money and expanded it to 750, I guess. And then we did, but there were a lot of clients that they were having trouble getting into that program because they felt they needed more intensive support than they could give, including some time often in skilled nursing facilities. So we spent a lot of time and designed what they now call the Adult Targeted Case Management System, which was a continuation of Partners but targeted a slightly different group. But following the same idea of the only way to deal with the LA system is to make it divided into enough component parts that you can have accountability for the component, for the people on a longitudinal basis. And you can say where that accountability rests, and you target very unique services to them rather than having a generic service that everybody's supposed to come to. That was the theme of what I tried to do in my time, and I think what Marv is trying to do now is moving that forward into comprehensive systems that deal with families and communities in a smaller scale even yet. So I hope that will turn out to be good.
I guess they have reorganized the department.
They are reorganizing, I think.
Yeah.
I'll have to tell you, in terms of philosophy, I didn't do a lot of reorganizing. I worked with the people who were there when I went to San Diego and worked on making the parts of the system work together better rather than changing the structure. Although I did end up changing the structure some in Los Angeles. I cut out some layers of administration, but I didn't change the rest of it. So you weren't dealing with different people at the community level. Try to cut down the layers above. So that's my philosophy about administration.
Well, I would think that it was especially important then because there had been so much change and so much shifting. And how else do you get people to stabilize what they're doing? Because if you continue with reorganization, then they never settle down.
No.
But now the department is very extensive,
It has
seems to me.
almost doubled since I left in budget. It's unbelievable growth, and it's wonderful time. Dave Jansen said to me before I left, "What do you want to leave now for, that they're going to have money?"
Yes, they have not only money, but I guess along with that, there's a better attitude about what the mental health needs are and who should do something about them. And I think for so long that was just on the fringe.
Yeah.
What have you been doing since you left? I know you've been involved. You did it, the history of the department. And I know you've been on numerous national committees.
I'm on the National Mental Health Association board, and I chair the Public Policy Committee for that board. And that's a 2-year assignment, last year and this year. It's a 3-year term. I expect to be reelected, but I won't be public policy chair. I'll have some other assignment because they try to move their chairs around. But that will keep me busy. They have 4 meetings a year, and quite a bit
in Washington.
Quite a bit of assignments in between to keep up with the staff. Wonderful staff at the National Mental Health Association. If you don't see what they're doing, you ought to try to get some of their things. Or they have a website now, and you can find out a lot of what they're producing. But they have produced some very good resource material for people to use around the country. The expansion of children's services for the school-based anti-violence youth initiative really came out of the NMHA legislative staff. Al Guida was the head of that unit, and he kept pushing that there was openings. This was a good opening. Put some more resources in mental health. NIMH and the Center for Mental Health Services didn't even push it. They didn't think it was possible. But he got it, and it was only $20 million that first year, but nevertheless that was a substantial increase federally, and then that has been increased again. So that was one of the nice things that came out of that shop. But they work on they worked on the restraint legislation, trying to minimize use of restraints. They worked on, just got a new bill that we've been working on for 2 years, finally introduced, which is the Intensive Community Mental Health Treatment Act. It's intended to provide a cohesive Medicaid reimbursement program. Instead of having to bill Medicaid for the inpatient, the outpatient, the day treatment, the medication, everything separately, to wrap it up in one intensive treatment program for like the Partners people. So it would have made life so much easier administratively if we could have had that then. So it seems to be a timely thing now, as people are understanding that integrated services are more useful than fragmented services. Then if the fiscal can be integrated as well, it would be helpful. So that's one of those things. Then I'm also on the California Mental Health Association board, and on their public policy committee. And I have just agreed to stand for president-elect. They don't usually run much competition.
That'll be a big job.
That'll be a big job. That'll keep me busy. I've been on the Healthy Families Advisory Panel. Healthy Families, for the tape, is the state children's health insurance program, federal program that was passed in 1996, late in the year 1996. And California got their program off the ground in July of 97, and the legislation that authorized it called for creation of the panel met first in December 97, and the legislation was passed with a requirement for a mental health provider and a substance abuse provider, a certain number of consumers and other representatives. So I was the mental health provider representative. And the board has, we report to the Managed Risk Medical Insurance Board, which is a gubernatorial appointed board that runs this whole program. It's kind of an oddball in state government. It's not really a department. It reports to this board instead of to the Secretary of Health and Welfare, but of course they work very closely with the Secretary of Health and Welfare. Anyway, the board agreed to make it term limited so you'd get more people on the advisory panel. So my term on that advisory panel ends next June. And I was chair of that for 1 year, last year. And as such, the statute also provides that the chair of the advisory panel is ex officio on the Managed Risk Medical Insurance Board. So I went to those meetings as an ex officio member. And there are only 3 out of the 5 authorized positions filled. So those 3 people have to make every meeting in order for them to have a quorum and do the business that needs to be done.
Why aren't there more?
Well, our governor doesn't like to make appointments, we gather. I mean, there were 5 on before, but they all had to resign when the administration changed.
Yeah, he's very slow about all his appointments.
He's very slow about his appointments. So one of the 3 asked me if I would apply to be one of the 5. He said, we'd like to have more. We'd like qualified people. We've never had anybody from Southern California. We've never had anybody with a mental health background on the board. He thought it was a great idea. So he was this big salesman. So I have agreed to seek the appointment. So I've sent my letter to the governor asking. And now this man, whose name is Soap Dowell, he was a lobbyist for medical association and health insurance people, so he knows docs and insurance like crazy. He's been retired for some time, lives up in the Sacramento area, and he's been pushing me, and he knows everybody. So he said, now I go to work.
That's a good
to
spot for you.
Get the appointment. I guess. The interface with health and mental health I probably am good at because I've been part of health agencies as well as the mental health. I've got a lot of opinions about it, but the kids stuff I know well, and I think it has a lot of potential. It turns out it may be a very cutting-edge kind of thing because we have parity now for mental health and insurance. That means that the health plans are going to have to take care of more than they ever have. They can no longer just send somebody to the public sector without any accountability on their part. So the interface issues are just starting to be visible. People are starting to get nervous about it. Well, in the Healthy Families program, the activity of the mental health directors in the State Department of Mental Health set it up so that the SED kids would be referred by the plans to the counties because it made sense. We've got this SED system being set up. They don't know anything about how to do all these other things that the kids need. So just send them to us, and then we could get 2/3 support from the feds.
What about mental retardation? Where does that fit in, if it does?
It does as a carve-out the same way that, well, all people who qualify for MR qualify for Medicaid, so they don't need the Healthy Families. Healthy Families is for families whose income is too high for Medi-Cal and not high enough to afford their own insurance. So it's that overlap. And the SED, the kids were eligible for the services whether the families bought into Healthy Families or not. We have to provide them, but this would give more revenue. Instead of being 100% match from the county, it would be only 1/3 match from the county and 2/3 from the feds. Well, that would be a nice incentive if you could make those things work. It seems like a logical incentive for the counties to make it work. So far, it has been like the emergency rooms and the crisis residential treatment houses. There hasn't been the critical mass for the counties to get the systems down to how to make this work. And you could say the same thing for the health plans. That they don't know how to make it work with the counties, and it's right now quite problematic. I'm hopeful that it will be resolved, because if it isn't, then the plans are going to lobby that they will get the money and they will take care of the kids and not involve the counties. And I think that would be too bad for the kids, because I think it would take them a long time to learn and to be able to deal with the rehabilitation kind of emphasis that goes with the SED kids. You know, all the work with schools and all the rest of it. It's expensive. It's high overhead to make those systems work. I don't think they're going to want to put that investment in, and they don't know what it's going to be.
If we have a voucher system, what is that going to do to children who need special care?
Just be more schools that need to know how to make those referrals. I'm sure that private schools are not going to, even with vouchers, accept SED kids. One of the issues today is that, yes, you may have a voucher, you may have money to pay, but that doesn't mean that minority kids get into the private schools.
Or even non-minority kids. Yeah. I was meeting a few days ago with a young woman who is, she called herself headmistress of the Chandler schools in Pasadena. And they have 420 students there. And it's hard to get in, and they're filled to capacity and always have a waiting list. I said, what will you do if the voucher system passes? She said, well, a couple of their teachers have said, well, they'll just go out and start their own schools. They'll just take them home. If they each take 6 or 8 children, they'll get $24,000 or $30,000, and nobody will pay any attention to what kind of care, what kind of teaching they do, and who the children are. It'll be custodial and nothing else. She was quite worried about it because they don't have room to take in any more, no matter what they pay for them. And I've been worrying about that, especially with children who are mentally ill or retarded. What will happen to them?
It's dreadful. Well, there'll be less money in the schools, in the public schools, and there will be a higher and higher concentration of the most difficult kids. And then they will still say, see, they're still failing.
Sure, they make it fail.
They make it fail. It's like the public sector care when it doesn't have enough resources. People don't put those two pieces together.
Yeah, that's one of the things about this election tomorrow that worries me. So I can't
think it's failing,
believe that it will pass.
No. Some strange things happen.
I want some personal information from you. You don't have anything personal. Did you know that?
History. Yeah.
Tell me about about your family.
Well, my husband is retired from USC. We ended up coming to Los Angeles because of him.
Where were you?
We were in New Jersey. Before that, we were married in Montreal. We were both McGill graduates, Canadians. And his department chairman decided that he was not publishing enough, and he thought he would help him get a job somewhere else. Thank you kindly. They didn't think he wanted him to stay at McGill where he was teaching. So Clarence went out and went to Bell Labs, the most prestigious research place, and did lots of research and published lots of papers. And while he was there, met a man who was from LA and had been a USC graduate and was teaching at Purdue. He'd been at Bell. He was a Purdue graduate. He wasn't a USC graduate, but he knew LA. I forget. Anyway, because of that connection, Clarence agreed to come out. And I said, "Oh, we'd never want to live in California. We'd never want to live in Los Angeles. You know, all the prejudices one could possibly have." But we came, and Clarence was very impressed with USC, and this was when Zora Gaprillian was working on his focus of excellence in the engineering school. Clarence liked that, and he's very, very fond of the gentleman who made the contact, whom you know, was Bill Spitzer.
Yes.
Bill and Jenny were very good friends all the years that after we moved. They were wonderful. But that's why we came to Los Angeles, from Bell Labs to USC. And I was teaching in a university in New Jersey when we were there, and had just started working with a juvenile judge. I've been seeing what kind of research we might put together when this came up. And I had, the other thing I'd been doing besides just straight teaching was they had a Master of Arts in Teaching program at the university. And I was kind of one of the psychology observers and mentors and so on, which I enjoyed. I also was the advisor to the Married Women's Club, which was the funniest thing because all the married women were older than I was, but they had to have a faculty advisor.
But they got old before their times because they didn't have you.
In those days, they wouldn't, this was one of the few places in the country that took part-time students and evening students. It was ahead of its time that way. The man it was a private university, and the man who founded it was a real entrepreneur and a real character. In fact, the day that Kennedy was assassinated, I came out of a class and heard somebody saying the president has been shot, and I was sure it was the president of the university because he was such a character. I thought, wouldn't be surprised that somebody took a pot shot at him, but that was my first thought. It couldn't possibly have been the president. Anyway, I was teaching there and doing a lot of stuff. I enjoyed the married women and that faculty advising. And they had a women's program. The dean of the school was interested in it, and his wife was a sociologist, and she was there. And they had a publication, an early publication, women something or other, but it was, women's issues. So they were very supportive of me and of the married women students on the campus. And so, wonderful old campus. It had been Florence Vanderbilt Twombly's home. The Vanderbilts and the Twombleys. Twombly owned the Erie-Lackawanna Railroad. His name isn't known like Vanderbilt, but he had about as much money, I guess. And they built this mansion in New Jersey, northern New Jersey. It was a replica of Hampton Court, 100-room. And after Mrs. Twombly died, nobody knew what to do with it. It was empty for a long time, and finally the university got it. Bought it, I guess, and did some remodeling and renovating. The upstairs in the mansion were the classrooms, were the bedrooms, and you could get 35, 40 students in one of those bedrooms. So you can see how big they were. And in between the bedrooms were marble baths, and they became faculty offices. So we had a marble bath that two faculty shared between the offices. It was fun. Beautiful, beautiful campus. She had specimen plants from all around the world, and we came in a driveway lined with lawn, backed by azaleas, backed by rhododendrons, and then behind that were, the huge tall trees. But the azaleas would grow to 10 feet. Well, maybe not 10, 8. Yeah, 8 feet anyway. And then the rhododendrons behind them to 20, and then the treetops behind them. It's gorgeous.
Sounds beautiful.
So anyway, we came here, and I started, after we got kids settled in and settled into housing, so I started looking for a job. And I was on the verge.
Did you already have children?
Yes, our boys were born, one in Montreal and one in New Jersey. So they were settling in, and we had to get them. I was on the verge of accepting a job with Arnie Beiser at the training center. The job that George Wolken had given up when he went to USC. That's it. And Then my friend George Mowat, who had taught with me at the University of New Jersey, was chief of the Evaluation Research Division at the county. And his research associate left just at that moment. She moved to Arizona.
Excuse me.
Would you answer the phone? I'll turn it off.
All right. I am.
Well, George, the history book details how the county department got the NIMH grant to start the Evaluation Research Division. And George came and did that. And I had appreciated working with him in New Jersey. We both taught one course the same, and we've shared preparations, and we had a good time with that. And I liked him. I thought he had an awful lot on the ball. So when he said, in fact, he had helped me make contact with the training center. To back up a little bit, I had decided that I did not want to do more academic work. I wanted to do something more practical, at least for a while, because I felt very much that I was teaching what everybody else had discovered, but I wanted something that I would discover.
But that's a laudable idea.
So that was where I was coming at it. So when he offered me the job there at the county, I jumped to do that. And a lot of what I did in the early days is in the history book. I worked on, I think one of the most dramatic things for me was the state hospital census tracting and trying to find out where everybody had come from and get that data down precisely, and how interesting it was to see these demographic characteristics and locations and so on. There was always a lot of opposition to Harry, but Harry's personality is perfectly understandable. But I did think there were a lot of things he was right about, and it's too bad that he didn't have a personality to win the rest of the community to be more supportive.
Yeah. Was it at the training centers that you met Helen Olander?
No, I met Helen. It was because I already knew her that I went to the training center.
Oh, I see.
She came to the interagency meetings that I ran for the Department of Mental Health, starting in the late 60s. Don Schwartz kind of got the idea going, and then it kind of shifted over into my responsibility as head of planning to have this interagency, and I guess we were the only group in town that did it in those days, so Helen came because she was interested in the mental health thing in general. She and Marcia Buck were the two friends that I made out of that group. Well, and Steve Fox was the other one. Steve was with DPSS in those days, and he ended up coming to DMH because I probably wouldn't have been interested in having him if I hadn't known him, but because I knew him from the 1970 time and liked him so much and respected him so much, I'm so glad that he came to work with the mental health department while I was there. So anyway, that's how I got to know Helen. Was she came to those meetings, and when I took a sabbatical with Clarence in Germany in 1974, and it was when I came back from that I said we've got to do something to make an impact, and worked on that La Puente application, and that I felt okay, I'd made some real substantial contribution other than just the bureaucratic stuff. I was very depressed and discouraged with the merger in DHS. It just seemed like we were the stepchild and nothing went well, and nobody wanted to understand and help these programs and really make it work, and they didn't have any understanding of community empowerment. Au contraire, they did everything they could to keep the power in their own administration. No malevolence. I like all the people. I've enjoyed them. I'm glad to see List at the party. I've seen List since I retired. I go to the retired department director's luncheon periodically, and he goes to it sometimes. So, we have a good relationship. But I don't think he knows yet how profoundly disappointed we all were. He saw it in terms of politics, not just just betrayal that people felt in that context. So I was feeling very, very depressed about what was the point of staying in the county, and that was not going, and what could we do that would be different and make some positive. And Helen said, "Hey, I'm getting this grant. Are you interested?" And yeah, I am. So it was a big change to go do that. And Dick Elpers served on the advisory committee that I set up for that project, and so when he had been chair of the Conference of Local Mental Health Directors, so when he was deciding to come to LA, I certainly had an active role in talking with him all the time about what he was doing and how the strategy was and so on and so forth. So it was natural to come and work with him when he became director. And I enjoyed working with him a lot. Learned a lot from him. He's always a tough guy. Tough on the outside and a bit tough on the inside. I guess the best psychiatrists are like that.
Yes, I think probably so.
I think so.
Well, I was interested to see John Schwartz. It was the first time I'd seen him at the celebration at the mental health department.
Yeah. He's a great man. Really, really good man. I was surprised Harry is as well as he is, because he retired out of a sickness leave with his eyes. I had always had the impression that he was much sicker than he was.
Don?
No, Harry.
Harry. Oh. I think that
that was his discouragement
under control.
Oh yes, yeah. It was his psychological response to the stress of that merger, I think. Just like I had mine, I went into. Oh well.
I think that's when he took up Zen, and he's a very ardent supporter.
Yeah. Anyway, what else? The personal, my family has been very supportive. I once during the merger time, there was an opening for the director of planning for the combined department. I applied. I was one of the finalists, but I said to them at the time, I have a family. I give 1,000% in the hours that I am expected to be at work. I even do some overtime, but I don't want to have to do a lot of that. I want to be able to go home and be with my kids in the evening and weekends. And I didn't get the job. I am convinced that it had to do a lot with this, a woman can't give 100%.
Priorities were not
priorities
right for
were not
them.
what they wanted. You see it still in lots of places, but I always, it didn't bother me. I was kind of glad I didn't, but didn't get the job. But it was just, typical of what things were like then. Oh, I've got a good personal story for you, I'll bet. When I was in graduate school, this is what I tell all the young women, because they just cannot believe this story. I had finished my master's degree. I was starting on the doctorate with the man who was at the time head of the Department of Psychology. He was an industrial psychologist who had a very active practice with big companies on executive selection. That was his specialty, getting executives. And part of the conditions for my being able to do the graduate school was to have stipend support from him for a research project, so that would pay the fees for the university. Not that they were high, but they were high relative to everybody's income in those days. Clarence was making $5,000 a year as a professor in those days, I think. So that was fine. I had a fellowship from him. And it was cool. And I had worked for Aluminum Company of Canada during my master's degree to support myself, just to pay the fees kind of thing. I found out I was pregnant in September of maybe October. It was just at the beginning of the school year. And I decided that before I paid my fees, I was going to make sure that he would continue the scholarship, well, the stipend, and not have any objection to my staying in the program. So I went to see Ed Webster and tell him this story. And his response was, well, it's too late to get anybody else, so yes, you can stay on the stipend this year, but of course you'll never finish. And he went on like that for a while, and then he suddenly remembered that I was scheduled also to be a teaching assistant in the introductory psychology course. Now, the professor of psychology who was teaching that introductory psychology course was Donald Hebb. I don't know whether that name means anything to you, but Donald Hebb was the outstanding psychologist in Canada. He was a president of the American Psychological Association. He had textbooks on the brain and behavior. He was one of the earliest researchers in brain functioning. Just, the outstanding one. And if you wanted to do anything in psychology, it was a great kudo to be able to say you had been a teaching assistant with Donald Hebb. So Ed suddenly remembers that I'm scheduled to be this teaching assistant in the class. I mean, there are 10 or 12 of us who are going to be, because it's a big intro psych class. Oh, he says, you can't do that. Why not? I said. He said, well, you just won't be reliable enough. Student teachers assistants have to be there every week, and you have to do that and that. Well, I burst into tears. He said, you see?
Proof of how unreliable.
How unreliable. Burst into tears. That was the end of the interview. And I was utterly horrified. So I went out and talked to, there were 2 women on the faculty at the time. One of them who was also taught that course with Hebb, and had been, a good friend. Quite a bit older than I, but still, good friend. So I went and told her. She laughed. She said, oh, Ed is just being so old-fashioned. Don't worry, I'll take it to the rest of the faculty. So the upshot was the rest of the faculty overruled him. Told him I could do that. Thank you kindly. So I did get to do that all year, which is interesting. Being pregnant in Montreal in the winter, and our department building was way up a steep hill. Not slippery. It was kind of interesting. Anyway, I took wonderful care of myself, and I didn't miss a day all year long. And I watched my weight and everything else. And at the end of the year, he called me into his office one day and said, I have to eat my words. I have to apologize. I will never again say that a woman can't do this stuff. Anyway,
you set a standard.
I
for
set
women.
a standard, yeah. Well, then the funny thing was I got sick with flu at the time of the final exams.
Oh.
The baby was due just before the final exams, so they had planned, they made an arrangement for somebody else to mark papers so I wouldn't have to do that. But I got sick a week before that, and I was sick in bed for 2 weeks. The baby was a good bit late. So I would have been sick in bed with the flu, whether I was pregnant or not, I guess, and couldn't have done the final exam, so they were prepared. The next year, one of my colleagues had married a young woman who was not in professional school, but a nice young woman, and she was pregnant the following year. And we all laughed because he missed at least a day a week with her pregnancy. But we all kidded a lot to ourselves. But anyway, I made the point with Ed. He never kept out a pregnant woman again. But it is unbelievable that it could have crossed my mind that he wouldn't let me continue. Number one, and number two, that he would respond the way he did.
No, that's really a learning experience for him.
Yeah. Yeah. So, good for young people to know that there has been progress. can't think of anything else, Francis. Our son, well, perhaps people would be interested to know our older son had epileptic seizures when he was 7 years old, 8 years old the first time. And because of the mental health department connections, they found me the best child neurologist in the city, who affirmed that that's what it was epileptic seizures, and left us in the care. We belonged to Ross Luce at the time. And he said the chief pediatrician of Ross Luce was a friend of his and the best pediatrician in the city, and there was no reason for me to do anything but stay with that pediatrician, and they would work together, and he would make sure. And that was Dr. Ballady was his name. That Dr. Ballady and he were in touch, and that was just took care of it. Dr. Ballady kept both the boys in his practice until they were 18, far beyond when they usually do adolescence. Rob had few times of grand mal seizures, not too many. A very bright kid, very bright and very competent. And he basically took himself off his medicine without letting me know, because I wasn't doing the count them out every day, but I'd suddenly say, Robert, there's so many pills here. What are you doing? He said, well, finally he confessed that he had cut down because he didn't want to be on pills the rest of his life, and he went fine 5 years without anything so he could get his driver's license and do all those things. Very determined young man. But later in his life, he has had a severe depression, and I have talked about that some. I did not talk a lot about it in L.A. I did after I retired, and we didn't know about it until close to the end of my time as director. But when I spoke in San Diego at the Mental Health Association conference in the fall of '98, I talked about it very much. Having him living here was a little harder for his confidentiality to talk about it a lot, and that had some concern to me, but we don't know for sure whether it was situational, whether it was affected by the early brain disorder, just, complicated things or what. He's fine now, but
he has to be watchful. Is he married?
Yes.
Has
married
family?
And has our only grandchild.
And what does he do?
He's a minister and an architect. He does both. He's credentialed in both, and has worked as both, sometimes together, sometimes alternately. He's
it's an interesting combination.
Yeah. He's a very high intellectual curiosity kind of person, and not the one thing is ever going to be enough for him, so he likes that change, that variety, which adds to the stress and then can add to the depression, although I don't know. It's one of those interesting challenges.
Yeah, I would think that it would be, and that he would probably have some insight into what he has to watch out for.
We hope so.
Yeah. What about your other boy?
The boy is a USC graduate in engineering, and he is now doing human service. He did engineering for a while, high tech, enjoyed that, but his personality is one that he really likes people, likes being out, and he wanted to try sales. And he tried sales with several companies and found that so many of them were so unethical, he was not real happy about it. And a door opened for him with a colleague friend of ours who started a service agency for seniors called Life Services. It is partly a private conservatorship, but it's a nonprofit corporation. It's the only nonprofit conservatorship agency, I think, in California. She started it 25 years ago, and so he's working for them now, and very happy. Gets along well with older folks. Sees this as an important contribution where he can have real pride in service and ethics and all the rest of it. So it's funny, how people come around to a service approach, but
that's what he likes.
He likes it.
Well, he's lucky to have gotten into it.
Yes. The founder of the organization would like him to take a master's in gerontology, and he's been with them a year now, and so, figured he needed to spend that time getting his feet on the ground and getting organized, but that he might well do that. She works a lot with the USC people. In fact, she has, blocking on the names, 2 or 3 USC alum emeriti, the head of the emeriti program, what's his name?
Paul Hadley.
Paul Hadley is on her board, and Art. Haven't looked at the names for a while, so I'm not knowing them. But anyway, lots of USC people on her board. So Kevin's real happy with that. His wife is a neuropsychologist, and she's at the conference in New Orleans that made the news today. You may have heard that somebody from San Diego reported at this meeting that they have been able to use adult brain stem cells.
Oh, I did. I read that this morning.
Adult brain stem cells, and not have to rely on fetal brain cells. So that's the conference she's at right now.
Well, that's pretty exciting.
Yeah, she has gotten a young investigators NIMH grant at UCLA. She's been went there for postdoc. Her degree is from UCSD, SDSU. It's a joint clinical and research degree program that she took there, and she's just been doing research here. And she kept applying and finally got a nice grant, so that she's now really in a permanent status instead of doing a postdoc, which is very nice. And she, since we're talking personal, I don't think I want all of this published, but
turn that off because I want to hear it.